And a very good afternoon. Goeiemiddag, Mulweni. You still tune into Sakisi's We're Building the Nation Podinasi. So we are discussing the so-called 21st century disease known as the endometriosis. And it is widely understated illness in South Africa that affects women's menstrual health and fertility. So as last month was International Endometriosis Awareness Month, we thought it is important to raise and create a little bit more awareness around endometriosis. And right now we will be speaking to an expert in the field, a gynecologist, and she goes by the name Dr. Abri, Bruin, the Senior Medical Director of Genius Reproductive Center and Head of MediClinic Kloof's dedicated multidisciplinary endometriosis unit. So good afternoon, Doctor. How are you today?
Good afternoon. Thanks. Sorry, I'm not a she.
Oh, apologies.
And the clinic is Genesis Reproductive Center.
Thank you very much, Doctor. And then also thank you very much for taking this time to speak to us today to educate us a little bit more and our listeners about endometriosis. So if you can firstly start by explaining a little bit more on what endometriosis is.
So endometriosis in essence is when the cells that women menstruate out every month, if those cells start growing outside of the uterus, that is called endometriosis. So that's the essence of what it is. So it's cells that you normally have in your body, but they just grow where they shouldn't be growing, and that is then endometriosis.
And how does that affect women's reproductive health?
In a lot of ways. So what it does is, firstly, by acting on your quality of life. So if it impacts on your quality of life and it causes pain. So typically painful periods, painful intercourse, chronic pelvic pain. So you sit with chronic discomfort in your pelvis, chronic pain. So that limits your enjoyment of life. It limits your enjoyment of a wedding or a married life. It limits your enjoyment of everything that has to do with reproduction, because if it's too painful and it's uncomfortable and it's sore the whole time, you don't want to do it. That also then impacts from that side on not getting pregnant, from a pain side. And then there's a separate side where the disease actually causes an impact on you to fall pregnant, because it can affect your ovaries, it can affect your uterus, it can affect the relationship between the tubes and the ovaries, because the tubes and the ovaries should be free from each other, because the tube needs to be able to move around the ovary to pick up the egg, because you don't always ovulate from exactly the same spot in an ovary. So the tube is amazing. It actually moves around like a little anemone in the sea where you ovulate in your ovary and it picks up the egg there. So if that relationship between the tube and the ovary is impacted by adhesions caused by endometriosis, so those are the direct effects of the endometriosis, and then the pain is more the indirect effect on fertility.
Why is it actually labeled the 21st century disease?
Look, I think what we need to understand, it's a lot more common than it was when I've qualified as a gynecologist. I'd never seen a patient with endometriosis. Now I have a waiting list of more than a year to see patients with bad endometriosis, not even just endometriosis. The question is, are we just picking it up more? Are we looking for it more? Is it more prevalent? I think all of those factors, the answers are yes.
And what are the common symptoms of endometriosis that women should be aware of? Because like you've mentioned, if you are on your period, it's very painful. So does it basically arise from an early age, or is it sometime during your life that you will be diagnosed with endometriosis?
Well, it starts early. It's not a disease that you wake up one morning and you have a lot of endometriosis. That's not how the disease works. The disease is a progressive disease. So if you have the menstrual blood that goes through your tubes, because your tubes are open and those cells then land in your pelvis, inevitably they will start growing there where they shouldn't be growing. And in some patients, it happens easier. In some patients, it doesn't happen. So we're not sure what all the factors are that make that it happens in some patients. But typically the patients will present with painful periods, chronic pelvic pain, pain during intercourse. That's your typical symptoms that the patients will present with. And if you look at what happens in the training hospitals, patients present with the same symptoms, but it's related a lot of times to infection. So then people tend to forget that endometriosis must be on your horizon of differential diagnosis. You must always think about endometriosis. And now that we're teaching at the university, the registrars and the students, that this is one of the things that you must consider as a factor when patients have painful periods, and not only infection. Now suddenly we are diagnosing it more, and we're actually doing more laparoscopies, which was not that often in the years gone by. So we're seeing a lot more. And now we actually get proper diagnosis, then the only issue comes in, we don't always get proper treatment.
So, doctor, let's say someone on the Cape Flats and you do go to the public facilities. How will you know that you do suffer with endometriosis? Is there a certain process or symptom factors that will indicate that this could be, because it's not always the case if you have a heavy period. It might be for multiple reasons that you are experiencing pain during your cycle.
You're absolutely right. You're absolutely right. But I can tell you now that if you go to the public facilities, doesn't matter where you are, whether it's in the Cape Flats, whether it's in any province in the country, you're going to go to the public facilities. Your chance of getting a proper diagnosis is very small, because you won't have proper access to laparoscopies. I mean, at Steve Biko Hospital, our waiting list for a laparoscopy for endometriosis can go up between 6 months and a year. That's in a tertiary hospital. So if you're going to go to a public hospital, your chance of getting a proper diagnosis is very small. So I think that if you present with painful periods, the first step would be to say, right, I'm going to start on the pill or on the injection, either one of the two. If my symptoms improve on that, I most likely have endometriosis. Because as you say, there's lots of things that can cause painful periods. And it's not always endometriosis. But if your symptoms improve on the pill, which is free and freely available at the clinics, or on the injectable contraceptive, which is also free and freely available at the clinics, then you must, as a patient, remember that, listen, there's a big chance that I can have endometriosis. And the other thing is that there's a direct family link. So you have a much greater chance of having endometriosis if your mom had endometriosis or if your sister has endometriosis. So maybe they've had that diagnosis, but it's also possible that they don't necessarily have that diagnosis. So then you won't know. But if you go to the clinic and they can give you the pill or the injection and your symptoms improves, then you must fight the fight and say, listen, I need someone to look further and make a proper diagnosis that I know what's going on so that we can plan my future.
Thank you for that. So this is again Dr. Abri de Bruin. We're discussing the issue of endometriosis and how it affects women's reproductive health and their daily life, and what are the solutions and ways of coping and then ways of addressing the issue, and also just detecting the issue as a woman who is concerned about their reproductive health.
And doctor, if you can also just tell us a little bit more about the challenges that you are faced if you are diagnosed with endometriosis. Like, is there certain lifestyle factors that you can change in order to make it better, or is there a treatment plan that is available to assist with the process?
So yes, I think one needs to look at the things that you can change yourself. So smoking negatively impacts because it decreases your immunity. And if you know that those cells land in your pelvis and you suppressing your immunity by smoking, that gives those cells a bigger chance to grow there. The other thing is that endometriosis is dependent on one of your female hormones, which is called estrogen. And if you are overweight, you will have more estrogen than when you are not. So the fat cells are actually converted to estrogens. So overweight, smoking, and then also what we eat. Because if we go to certain stores where we buy our food and we buy it there because they last long, we must ask ourselves, why does it last long? And there's a lot of things that we eat and drink that contains a lot of hormones. And we think that that plays also a very important role in getting this disease to continue to grow. And then with regards to a treatment plan, the issue will be to make a diagnosis. Once you have a proper diagnosis, because there are 4 stages. If you're on the early stages, stage 1 and 2, taking medication that's specific for endometriosis is going to help a heck of a lot. If you have bad endometriosis and it starts affecting organs, and I mean bowel, vagina, ovaries, it can affect lots of organs, then you need to be treated at a proper multidisciplinary team that deal with bad endometriosis on a daily basis. Then it's not just a laparoscopy that a normal person does. GPs shouldn't be doing laparoscopies for endometriosis. Gynecologists can do laparoscopies for endometriosis, but not for the advanced stages. There are certain centers of excellence that deal with these bad endometriosis cases, and that's where we want these patients to end up, because that's the only way that you're going to have your fertility preserved and have a chance of actually getting pregnant if we can actually get this disease early and treat it properly.
And doctor, you've mentioned the 4 various stages. So can it be mistaken for fibroids also? And is it cost effective to go through these treatment plans?
Can it be mistaken for fibroids? No. The difficulty in endometriosis is how do we diagnose it? So the ideal diagnosis is that there are some endometriosis that we can pick up on ultrasound. So people tell you that you can't see endometriosis in ultrasound. It just means that they can't do an ultrasound. So endometriosis in the bladder, we can see on an ultrasound. Endometriosis in the ovary, we can see on an ultrasound. Endometriosis in the bowel, many times we can see. Endometriosis in the vagina, we can actually feel. So there are endometriosis that you can pick up clinically and with ultrasound. The fibroids is very easy to diagnose on an ultrasound. The other thing that people worry about is can it be confused with polycystic ovaries? No, that's also a completely different disease. So no, you can't mistake it for fibroids, but I've just seen a patient right just before this interview with fibroids and endometriosis. So you can have both. That's also important. But you can't mistake the one for the other one. It's two different things.
But does it make it more common to treat it if you have fibroids and endometriosis?
This makes my surgery longer because I have to remove the fibroids as well as the endometriosis.
Okay, good to know.
It's just a question of we're going to do actually 2 surgeries in one. So we're going to do a laparoscopy and at the same time remove the endometriosis and at the same time remove the fibroids. So just extend your theatre time and how long you're going to be operated.
As well as the issue of cost effectiveness, is this something that would be affordable for someone, or are there solutions if the affordability is not there?
No, that's the problem. What we do know is that the generic companies are now producing endometriosis tablets. So the patent is still there, but now the generic companies can produce endometriosis medication, which is a lot more affordable than the initial medication that came onto the market. There's about a 200 Rand difference per month in the new generic medications. So that at least is something that is of a huge help. Unfortunately, to make a proper diagnosis, you need surgery. So which you're not going to get in a clinic, which you're not going to get in all the state setups. So if you're going to go to a private place to have that done, it's going to cost you a heck of a lot of money. So I wouldn't just go and have a laparoscopy done anywhere. I think if finances are an issue, you need to know that we really think that you have endometriosis. If you're going to pay for surgery, you must pay for surgery once at the correct people. Because I see too many people that tell me that they go for their 6 monthly laparoscopies. That is nonsense. That's stealing from the funders, and that's just not what we should be doing.
Doctor, just a question on that. Like you've mentioned now, if they do come back for the 6 months, which you mentioned, that is nonsense. If you were diagnosed once with endometriosis and it was treated and removed, is there a possibility that you can get it again?
Yes, 100%, because it depends on how bad the endometriosis is. So if you have stage 1 and 2 and we burn the endometriosis, which I don't do, but many people do, 75% will still be there in 6 months. If you cut it out, there's an 80% chance that it will still be gone by 5 years. So you either have a 75% chance of still having the disease in 6 months or an 80% chance of not having the disease after 5 years. That's for the early stages. For the later stages, it's more difficult because the more extensive the disease is, the more microscopic lesions we will leave behind. And it's not really that the disease recurs. It's more that the disease that wasn't removed completely just carries on growing. That's why we look at 2 groups of patients. One where we're just treating quality of life, so we'll operate them and most probably put them on the pill directly following the surgery and keep them on the pill and try and get them not to have their periods. Or if we have a fertility patient, we're going to try and treat them and immediately after that try and see how quickly we can help them to get pregnant.
Doctor, and just before I let you go, so in your personal experience, what are some of the psychological and emotional challenges that women are faced with dealing with endometriosis, especially when we are referring to the infertility?
Well, it's not only for that. The emotional things is you have a disease that no one can see. So you can tell someone that I have this excruciating pain, and I have pictures of patients that burn themselves with warm water bottles. It's an invisible disease. No one can see it. You can't tell someone how bad this pain is because no one can understand it. It's not like a broken bone that everyone can see. You broke your bone and now you've got a cast on it. Okay, that's the problem. It's an invisible disease that no one can see. It negatively impacts your daily life. It negatively impacts your quality of life. So the psychological impact with pain-wise, and pain drives people to sometimes lose their mind and do stupid things. I've seen patients commit suicide because of pain. All know that cancer patients suffering from very bad pain will eventually also do something. And on the other side, I mean, part of a woman's reproductive life is to have kids, and now you have a disease that's preventing you from having kids, and that also has a huge psychological impact on your life and of your partners.
What we've discussed has generally been a dark or a bit sad subject, given the issues detecting them and the solutions that are currently available. As we wrap up, do you have any messages of hope or encouragement that you would like to share with women who are navigating the complexities of endometriosis and fertility issues that come with it?
From more than 15 years of dealing with really bad endometriosis, pregnancy rates are more than 60% in the correct units. So there is for sure hope we can get patients pregnant that have stage 4 endometriosis. So not only us, but the true centers of excellence, people that actually really do the surgery. They don't just say they do it, but actually have proof that they are doing it and that they have numbers and what their success rates are and what their pregnancy rates are. So there's definitely hope for even stage 4 endometriosis patients of more than 60% of chance of getting pregnant. So for those with less extensive endometriosis, it's even better.
Thank you very much, Doctor. Just before I let you go, are there any contact details you can convey to the public if they want to know a little bit more about endometriosis and the process?
I am updating my website at the moment, but they can contact us as well at MediClinic Kloof Hospital, and then we'll also share with them the information that we have. Pretoria 012-367-4374.
Doctor, are you based in Pretoria or here in Cape Town?
In Pretoria. I have a very good colleague in Cape Town that is also very good with endometriosis. There's a lot of people. Professor Ignas Siebert is the one person that also does a lot of good work with patients with bad endometriosis. There's Dr. Katie Bruin in KwaZulu-Natal that does a lot of good work with endometriosis. There's other people as well. Those are the people that do a lot of bad endometriosis.
Thank you very much, Doctor, for taking the time to speak to us today. Have a beautiful day further. Any last words from your side?
Thank you for having me, and I just hope the patients understand that you're not alone. There's a lot of people out there, and make sure that people understand you have issues and you would like to have it solved.
Thank you very much, Doctor. Have a beautiful day further. Bye.
You too.
So that was Dr. Abri de Bruin, the Senior Medical Director of Genesis Reproductive Center and head of MediClinic Kloof's dedicated multidisciplinary endometriosis unit. He gave us some valuable information about how to cope with endometriosis, how to treat it, what are the possibilities of that, how to detect it, and more.